My name is Stephen Liu. I'm a thoracic oncologist from Georgetown University. When we think of the ongoing debates in lung cancer, I think we can notice a theme, and the theme really is, are we delivering the right treatments to every patient? While we've certainly made advances in terms of identifying certain subsets of lung cancer, delivering targeted therapy to tumors who harbor a driver alterations, I think a bigger question is, are we over-treating some patients? When we look at our large studies, we can show that different combination treatments are improving outcomes for large populations, but they're also adding cost, adding toxicity. Is that cost and toxicity necessary for all patients? If we look at the EGFR space, for example, we have two combination regimens which have improved outcomes clearly over TKI alone. FLAURA2 showing that when you add chemotherapy to osimertinib, we improve progression-free survival quite a bit. The Mariposa regimen showing that when we use amivantamab and lazertinib instead of osimertinib, we improve progression-free survival, we improve overall survival. And those improvements in outcomes certainly warrant these as new standards of care, but does everyone derive that benefit? Can we identify the patients that don't need that combination therapy to get the same outcomes? Are we over-treating some patients? And our outcomes in lung cancer still have a lot of room for improvement. So there's some hesitancy to pull back on treatment. I think another example is in this early stage space. When we look at perioperative therapy, we know that adding neoadjuvant immunotherapy, nivolumab in Checkmate 77T, pembrolizumab in Keynote 671, durvalumab in Aegean, that giving that immunotherapy with neoadjuvant chemotherapy improves pathologic CR, improves event-free survival. And we saw with Keynote 671 that translates to a survival benefit. Those regimens, though, also include an adjuvant component, a postoperative component. How necessary is this? Again, are we over-treating some patients? Are we delivering some treatment that's not necessary? How do we properly study that without depriving patients who need that extra treatment to get that benefit? I think this is one of the big challenges, not to over-treat, but also not to under-treat patients. And to really move the field forward, we need more reliable, consistent biomarker studies. These need to be shown in the ongoing trials and then really applied in large global collaborations to really try to spare patients cost, spare patients toxicity, really focusing on giving people the treatment that they need, but really trying to avoid giving people treatment that they don't need.